Hello, everybody. Hello, Alicia and Jennifer. How are you guys?
Doing great.
Doing great. Yeah. You know, it's supposed to be the last of the hot days. It was only, I think, 104 today, and yet 2 days ago, 106. It's going to be just in the 90s next week.
I lost my AC today on this floor, so I'm glad it's not 104 here in Flint, Michigan, put it that way. Yeah. And Jennifer is like at the end of her rope. She's moving, and she took time out to be with us in this webinar tonight, so thank you, Jennifer. Alicia thanks you for participating again with the CCO team. And how's it going for you? How are you, Jennifer?
Oh, me? Yeah. Oh, tired.
I bet.
So,
if anybody who's out there who's moved, you know what she's going through.
You know, because it's Eastern time. So when I'm done, like 10 o'clock, I'm still going to go pack some more.
I hear you. Well, welcome everybody to the August 2020 Certification Q&A Webinar. I wanted to say CCO Q&A Webinar, which is really what it is, but I'm just reading the slides because that's the dumb thing to do, right? For us guys who do too many webinars and Zoom calls. That's why we have slide decks. So welcome everybody. If this is your first time, we want to hear from you in the chat. We're going to do a little survey here in a bit. We can go to the next slide there, Alicia. And this is, if this is your first time here, we're going to find out if this is your first time, but welcome to the CCO community. I'm Boyd, your host, along with Jennifer and Alicia, our CCO resident subject matter experts. So this is a medical business certification, medical coding, billing, and practice management related webinar. Again, for those of us who have been here before, you know that we cannot hear you. You can always type a question in the chat and we'll attempt to answer it during the webinar, but believe me, it's not easy with so many people on the webinar. And please stay to the end for a giveaway. That is the message I want to make sure that we get everybody into tonight. Our length is about 60 minutes, and we've got some prepared questions. Again, you can ask a question anytime, and if you don't get your question answered, you can go to cco.us/topic request and get it going. I think the next question is probably, what are we going to cover tonight? Alicia, do you want to tell us? I think it's in the next slide in the agenda if all goes well.
Yes, we've got some really cool topics tonight. What do you code when you have a patient that has bronchiolitis and gets diagnosed with COVID? And then time-based codes for ICD-10 CM. And I happen to know that you did put CPT codes in there too, right, Jennifer?
Yeah, I just kind of changed it to time-based codes. So
good. And she's also going to talk about the core credential description. Some good questions came in about that. Let's see. I'm going to talk about HPI documentation. Who can document in the HPI? Colon screenings, the codes and modifiers. Yay me. And then Jennifer's going to wrap us up with chief complaint documentation. So again, lots of documentation going to be talked about tonight, Boyd.
Nice. Nice. So how many webinars have you attended? I think I'm on the Windows machine, so I think it's safe for me to, oh no, you're presenting, right? How about you try launching that from your side?
Okay, I got it.
Sometimes when we do this and we start sharing duties, then things get messed up. We've discovered.
It's launched.
So is this your first time? Is it between 2 and 5? We call you a repeat offender. Is it between 5 and 10? Which means you're liking it here at CCO, and your CCO frequent flyer is 10 plus anybody out there. I'm sure that we've got people in all of these. And what does it look like? The faster
we've got 68%.
Faster you guys.
69, 70. Can we?
Yeah, why not? The faster you guys vote, the faster we can get through these, because we just want to keep you awake here at 8 o'clock Eastern. So the survey says, for those listening on our audio conference line, I don't know where that is, but just in case. First time, 28%. One, back for more, 7%. Repeat offenders, 14%. Liking it here at CCO, 5 to 10, is 15%. And CCO frequent flyers with the winner tonight at 36%. Welcome, everyone.
You know, let's say a special shout out to Angelica, says it's her first time, and Kathleen.
Nice.
So, hey,
I know Kathleen. So
you do?
Yeah, so it's interesting to see her name. Yeah.
Nice, nice. Why stay to the end there, guys?
Mm-hmm.
Oh, if you stay till the end, not only will you see a little after show because we talk about some Q&A that wasn't on the regular list, but you get to win a prize. Yay! Golf clap. So you get to choose between 1 year of the CCO Club, an hour consult with one of us, or you can get the CPC Review Blitz or one of the other blitzes if you'd like. So honestly, we don't mind telling you the best deal is the CCO Club, but you can pick whatever you want. It's that 1 year of CCO Club is pretty cool.
Yep.
I can't imagine anybody want to talk to me for an hour.
Wouldn't you do all the talking, Alicia?
You're right. I would.
We're going to talk about the slide that's on your screen right now, which is talking about our CCO Club a little bit later in more detail, but we just want to let you know that it exists for those of us who are here for the first time. And it's all about getting CCU. Sorry, go ahead, Alicia. You know better than
I was just going to say, I really like to say, if you want to find it, just go to cco.us/club. I don't know why, but I got this / thing in.
/ Graduates, we have one in COVID-19 coronavirus life that we all are in. You know, lots of these things are kind of just dripping in. So we've got one slide for CCO graduates that have communicated something. And I practiced these because I thought it was just going to be me and Alicia on here. So I'm going to see how I butcher these tonight. Okay.
I was just going to say, you should let Jennifer read that slide.
Okay, but Jennifer's whited out. So
there you go.
Yeah. So
okay.
avoid practice.
Khabib Pogisian, I hope,
Good for you.
got their CPC, and I believe we have correct dates here at 8/11/2019. So this has again just been communicated. They use the BAT system, the CCO Club, the CCO Q&A webinars, which you're on right now, CPC course, the PBC, the CPC Blitz, and the practice exams. And Murphy got her. I don't know, Khabib, if you're a male or a female. So excuse me, we have to figure that out. At some point.
Amy.
No,
Is
not
it
Amy,
Amy?
but yes. But anyway, I was just thinking about that. I didn't know if I said his or her. So apologize if in advance. 8/13/2019. Arnie Murphy, yes, got their CPC.
Amy. I think that's an M.
I don't have my glasses on. That's why you're right. You're right. I mean, I'm never going to do this again. I just been voted down, right?
No, you keep going. Okay. I'm having fun.
They got the BAT system, the CPC course, the CPC Blitz, the ICD-10 CM Blitz, and the practice exams. And Joywell on 8/13/2019 got their CCS using the BAT system, CCO Club, CCO Q&A Webinar, CPC Blitz, ICD-10 CM Blitz, ICD-10 PCS Blitz, practice, I can't say practice, exams today. What I notice when I read all of these is not just one thing that allows people here at CCO to get their training. They're taking advantage of the different products that we have.
You know, I think that's a true statement. And the CCS. Because a lot of people say, oh, well, I think I want the CCS, though. It's like, we have education for that. We've got lots of great tools and a course. So, yeah, don't forget that we can help you with multiple different credentialing organizations.
Well, I picked up that they all had the practice exams, which is very
key.
beneficial in being successful. Yeah.
Yeah. Oh, right. Well, I was just checking that nothing else came in the chat that
except Alicia wants to talk, or Whitney wants to talk to you for an hour.
Whitney, we love you.
Should be sick of our voices because she attends every single webinar. It's amazing.
And that's
let me tell you, last week she came to mine and then jumped right off and went to use.
And asks an average of, I think, 10 questions. So you should just definitely join the team and just, fill up all of our nuggets for the next year, I think.
Yeah, she does. And I'm giving a little, kudos to Whitney too. She has several credentials and everything. So even these webinars and what CCO doesn't just train you to get a credential. it's valuable on several different levels, like Whitney, who attends a lot of our, well, I'd say almost 98.9% of our webinars. And then she comes up with other things that to tell us that are useful. It's not just her, but it was several other people that we recognize names that, so good stuff. Good stuff. We like seeing that.
Yep. So this is our prepared questions that have been submitted by you, our audience. And I believe, who's got the first one? Yes.
I do. Yay. All right. So the question that had come in is, if a pediatric child comes in both with bronchiolitis and is diagnosed with bronchiolitis and the coronavirus, what should the code set be? Now, I am going to pull that. Excuse me while I do my two monitors and get used to having them in a different spot. This is actually pretty quick. Now, they put the coronavirus in 163. Forgive me, I couldn't find that. So I'm assuming they meant COVID-19. And if there is another one, then it's still, it won't be the coronavirus 19 code, but there will be another code for it. This is going to be actually kind of short and sweet. There's lots of training out there, but I wanted to make sure that I gave you the main codes that are what I call the power codes, or the power players for the COVID-19 world. These are codes that would be really, really smart to go ahead and make yourself a little cheat sheet. If you're in the club, you could have access to this, and you'd be able to, look at it again and again, another perk for being in the club. But these are the codes that you're going to see from this point on in our world. COVID, they're talking about it hanging around a lot longer than a regular flu season would. So let's break down those codes for you quickly. And again, there's other codes that are applicable. That would be things like signs and symptoms codes if we didn't have a diagnosis of COVID-19 yet. And I didn't go over those because we actually have several training videos in YouTube already on those. So I would just direct you to our YouTube channel, Medical Coding Cert, for those. But specifically, I wanted to highlight, because of this question, the codes that you need at your fingertips. The first one, the main one, the U07.1 is COVID-19 infection. But something that you need to be aware of is it means it's a current infection. And I also really broke these down and paraphrased these so that it's real easy to put them in a cheat sheet. A lot of times, you'll notice that I'll go in, or we go in and put in the whole description from the code. You won't necessarily need that all the time, especially if you're going to be using these as often as you are probably doing that now. And even for testing, this needs to be something that you're familiar with, because the tests going forward, I guarantee you in 21, you're going to start seeing a lot of test questions regarding this type of coding, because it's been so prolific this year, and they want to make sure you understand it well. First code, the one that dropped in the middle of the year, unlike we've seen before, U07.1 is a patient that has COVID. It doesn't have to be a test confirmed COVID. It just has to be documented by the provider that the patient has COVID. Now, you say, oh, wait a minute, don't they have to have that test back? Well, quite frankly, the provider is the one that makes that decision. And it would, if they say that the patient has COVID because they have the signs and symptoms and so on and so forth, it would be the same as if the provider came in and said, oh, he has hypertension, or he has he has a cholesterol disease or something, So again, the the COVID diagnosis is made by the provider. So if the provider states the patient has COVID-19, you're going to use U07.1. Keep in mind, like I mentioned, it's current COVID though, because that changes things. If they come back 2 weeks later and they have no signs and symptoms, and the provider says, you know, that they are going to run another test, but he thinks that, you know, the COVID's over for them, so on and so forth, but they still have some side effects. That's different. They no longer are a U07.1 because that's the current COVID. It's like having a stroke, a CVA. You know, you're not going to keep coding the same I code for a patient that had a CVA a month after they had a CVA. You're going to code the late effect or the sequela of the CVA. So if a patient comes in and they no longer have signs and symptoms, and the provider is stating that they don't have COVID, then they're going to be a Z86.19, right? Personal history of COVID, because what does the history code signify? That they no longer have the disease and they are not being treated for the disease. There's no signs or symptoms. So therefore, they're a Z86.19, not a U07.1. And I can see all kinds of really baseline test questions coming over something like this. So make sure that you understand that. Now, let's state that the patient comes in 2 weeks after the provider states that they don't have COVID anymore. They have a personal history of COVID now, but they have some late effects. They're having some breathing issues still. And so the provider wants them to continue with the rescue inhaler. And so what are they now? They're a B94.8. They are a sequela of an infection, and therefore B94.8 and Z86.19, but they are not a U07.1. Okay, very different. Now, let's say that patient A's spouse comes in and says, oh, I have a fever. You know, I'm not feeling too well. And patient A is now a Z86.19, has a little bit of a residual late effect, B94.8, and the spouse comes in, patient B, and they are a Z20.828. They've been exposed to COVID. Do they have COVID? Just because they have a fever, the provider may say, you know what, that's the only sign or symptom that you have. Yes, you have been exposed, but we're going to do a test, and I really don't think you have COVID for whatever reason. That they unlike when the first patient came in, they said, no, you have all these signs and symptoms, you've got COVID. Okay, and so the provider chooses to have you code the signs and symptoms, which would be the fever and exposure, and that they do a test. Okay, so very, very different. And then what about R76.8? I think it's an overlooked code because it's a sign and symptom code. It means other abnormal serum test that was done. So we tested for COVID. So what code are you going to use for that? And it came back abnormal, R76.8, but it didn't test positive for COVID, because if it tests, well, you could use it for COVID too, but needless to say, it is the test for COVID. No, it's the signs and symptoms for COVID saying an abnormal test had come through. Now I'm confusing myself. One other code that to be aware of that you may see, and this is what happened to me. I had to have a biopsy done. My mother-in-law is getting knee replacement done on Monday. I had to go in 48 hours before my procedure to be tested for COVID, even though I had no signs and symptoms. So that was a Z01.812. My mother-in-law got her test today, and then she's having her procedure on Monday. And this is where you usually pull up in the car, you tell them what's happening, they look up and they find your name, and then they do a COVID test. And it could be a mouth swab or it could be a nose one, but the mouth swab is what I got. They said that's a rapid test. So what are we going to do for this? Hold on. Something happened.
You're still with us.
Okay. I see now. Let's see. I got to get my screen back. Oh, I see it over here on the other side. I think I hit my mouse and it messed everything up. There we go. Okay, so what are we going to code for this patient that is mentioned here? You have a pediatric patient come in. They have a diagnosis, but the patient also has COVID. Well, there is 2 valid diagnoses. J2 1.8, acute bronchiolitis due to other specified organism. What's the other specified organism? COVID, UO7.1. That is the 2 codes that you would code. If the patient had, for some reason, my screen is moving on its own. Do you see that? Are you guys seeing that?
Yep, that's not you.
Or is it just, it's not me? Okay. So those are the codes that you need to know. And what I would advise you do, jot these codes down real quick. If you're in the club, you'll have your access to them. And they are the ones that moving forward, there are tons and tons of articles being written. We've done several lectures on it. Feel free to go jump out to Medical Coding Cert to look at those, as well as in the club. If you can't find something in the club you're looking for, just ask and we'll make sure that you get it. All right, let me bring up that other thing. There we go. We're ready for another survey.
Okay, I thought that this would be interesting because I am sending my kids for the first time back to school. So I was curious about our community during these times. If you have children, are they starting school this fall, 2020, during COVID? And that's what the survey is going to ask us here. And if I missed a question, let me know. I tried to make it so that if you don't have children, you could also say that. Not applicable for me. And if I missed an option, let me know in the chat here somewhere. So either yes, we are back attending in-class education, which is the case here for my family, my 1st grader and my 6th grader. I thought my 5th grader was actually going to grade 5, not 6. I felt really old that morning. They're growing so fast. Second option is yes, attending classes, online classes. I know, Jennifer, you're doing that with your kids, right?
Yeah, most of them are doing online. Yeah, my son's doing a homeschooling program, so yeah, online. Yep. Yeah.
And maybe your school or state is not ready to return back to school. I know our Davison, which is the next county over there, they don't have enough bus drivers actually, because they don't want to come back to work, or they retired basically, so they had to delay, and not enough teachers too. That was another thing. So that's why not all things are just safety related. Put it that way. What have we got there, Alicia, for votes so far?
We have.
Okay.
There you go.
Oh, yes is only 8%. Online is 25%. And no is 5%. And not applicable for me is 62%. Interesting.
That's interesting. Wow. So
mean
that actually tells quite a bit.
I don't know what that means, but
went back.
There's probably a lot of reasons for not applicables, but okay, cool.
Our schools went back 2 weeks ago, but my kids are homeschooled. They were homeschooled last year, so we just did it again.
Gotcha.
Worked out good.
All right. Next question. Oh, actually, we've got a sale coming up. This is a unique time to get 30% off all of our courses and blitzes here at CCO.us. And you can see that from that graduate slide, how they took advantage of all the courses, and this is how they probably got a lot of those courses when it was on sale. So if you go to cco.us/BTS, back to school, that's short for, that will get you in and give you an idea of what's available right now.
Yep.
Any other thoughts to share there? Good.
No, I just think that if you're going to have time on your hands, this is a great time to go back to school.
Right.
I don't know how many of having time on their hands, but talk about that time-based codes.
And Jennifer.
What a segue.
Well, we had a question. If somebody's having, and we hear this often, squabbles in the office, who's right, who's wrong. So we're having trouble in the office with codes that need time documented. Our providers do not want to document the time, and we keep telling them we can't use that time unless they include it. So what's the best way to get them to understand or convince them how important time documentation is? So, and since we were just talking about the sale and we were talking about credentials, I will let you know that my CPMA I got from one of the blitzes here, so on a sale. So before I joined CCO, I did buy a blitz on sale and did my CPMA through that. So yeah, I thought it was a really good way to go. So there are time-based codes that we deal with. A lot of them are in CPT, and the majority of them we might see in the E&M, Evaluation and Management section. Chronic care, critical care, counseling, prolonged services, a lot of those codes have a time increment with them. But then as you look at them, there's also descriptions that will say typically. So I just pulled up two just to kind of bring it together. So a 99241 is an office consultation that requires 3 key components: the history, exam, and decision making. And then you'll see underneath that in your CPT manual say typically 15 minutes are spent face-to-face with the patient.
Can you make that a little bit bigger there, Alicia, please, just for everybody?
Oh, a little bit bigger, yeah. Versus a 99446, which is a critical care face-to-face service, first 30 to 74 minutes of hands-on care during transport. So that's just one of the codes that distinguishes an amount of time that must be used in order to provide that code. And then there's an additional code for add-on code for each additional 30 minutes. So just a little bit of the two descriptions that you might see when it says typically 15 minutes spent. That doesn't mean it has to be 15 minutes. That was CPT's way of throwing in if the provider deals with time, which is going to change in 2021. So, and CPT defines floor time, hospitals attending physicians, there's a lot of different rules for, clinical staff. Do they get to do some of the time, or is it the provider who's doing the time? So time is going to change in 2021, and we're not going to get into that right now, but AMA has, there's the link included, so they're changing the 2021 E&M requirements, and this time we can allot for time, which is what a lot of people are doing right now during COVID. Because of a lot of telemedicine, they are using the time basis for that. But there are other sections of CPT that require time requirements. So some CPT codes in the cardiovascular or nervous system, they have a day requirement. We also see it in radiology. Fluoroscopy will indicate up to 1 hour of the physician or other qualified healthcare professional's time. Spectromography is done over 1 or 2 days. So there are time requirements. Basically, most of them are in the medicine section if they're not in E&M. So we see psychotherapy, biofeedback, therapeutic services, monitoring services, behavioral services, hydration uses time. So a lot of them have a time basis to it. So what do we do when those requirements are met? So I wanted to think of it this way. If you scheduled if you knew the patient needed 3 coronary stents, but only 2 were documented, what are we doing? Well, we're only going to bill the 2, right? The same concept. If they didn't document the size of the wound, well, we have to go to the default, the lowest code. If 3 elements are not fully documented in E&M, we go to the default, the lowest code available, or the lowest, problem focused or established expanded problem focus. So problem focus, it becomes Even if they might have done a comprehensive, we fall down to that problem focused if they're not documenting properly. So there are some defaults already built into our codes that we use the lowest. So how do we count time? The AMA, which writes the CPT manual, has a definition. Contrary to CMS, which is one of the largest insurance carriers and kind of the golden rule for the other insurance carriers, they have a different definition of time. So AMA considers units of time to be attained when that midpoint is passed. So if you have 1 hour, if you've done the 31 minutes, you've gone past that midpoint, and that counts as that time. Where CMS, a lot of the therapy services especially, will use the 8-minute rule. So they, in that table, can go on continually for up to 2 or 3 hours for the dependent upon the number of units. So how can we get, it's difficult to say, the provider trying to sit down with them and explain, well, this code is time-based, I can't bill it, and I'm going to have to mark it down to the lowest one because you didn't document it properly. So some of the best ways that work for providers to kind of draw their attention: perform a random audit. Take every provider, if you're in an office with only one, of course he's the one at fault, you already know that. But even if you have 2 or 10 providers, you do a random audit. So quarterly is good, twice a year, definitely once a year for sure. And you just draw 10, randomly pick 10 of their charts or 15, randomly pick a number of charts depending upon the type of practice you are and the size, how many patients you see an hour. And then you present the findings. Most times physicians either have a staff meeting or a physician meeting, and then you present the findings to them. Maybe not you, maybe the business manager or the practice manager. You don't dog somebody out and go, oh, Dr. Jones, you're the bad guy here. You just kind of present them, go, here is a sample. This is what we found. These cannot be billed because we did not meet this requirement. And a lot of times that might draw their attention to go, wow, you audited 50 charts and 20 of them are wrong. That's a lot of money, especially when it comes back for an audit. And then, of course, the errors you find, you need to correct and submit to the insurance carriers. So identify those errors. They could be positive, they could be negative. You could say, hey, you missed money here. Not just that you did something wrong, you missed money. We missed an opportunity to get some money for the services you provided to this patient. There are EHR programs or an app perhaps that can be added to your EHR program where it can document that time. So some programs can document, once the provider clicks, that they want to access that record, and then that they're going to see the patient directly afterwards, and, kind of requires them to be on par with that. But at least it could document the time for them without them going, oh, it's 10:14, I got to go in, I'm going in the room, I come out at 10:27, okay, that's close to 15 minutes, without the provider having to do that. You could have an app, or the program could possibly do it for them. Scribes are aides, especially in physical therapy or occupational therapy. They have technicians, or I used to be called an aide when I did it, but technicians or assistants that are the ones tracking the time that the patient is spending on a modality or on a machine. Again, I wasn't sure where this question came from, what kind of office they were, what kind of facility they were. So I'm trying to make it general enough to use in any circumstance. So especially in something like physical therapy, which has a lot of time-based requirement codes, you have somebody else doing that for them. So then the provider is freed up to do some more of their services. So somebody else is saying they spent 5 minutes on the treadmill and 5 minutes, whatever, doing their neuromuscular reeducation. And a scribe coming into the room, they can document the time that it came in. And it may be a cost benefit. So it may pay for itself. Show them those OIG reports. Bring up the OIG reports of the audits that they've done over the years. And definitely physical therapy time-based is one that they definitely do. And any other time-based, you can look at that as well. So the OIG reports come out, they're published on the OIG website. They might target specialties who do this. They target physical therapy because they know it can be a problem. Randomly perform audits of those types of providers to make sure that their documentation is correct. So definitely bringing it to their attention and being able to see it, because the providers are there for patient care. We need to keep that in mind too, that it may be, the coders or the manager's duty to educate those providers on the requirements, because they're not coders. The same as our coders, we don't make that medical decision because we're not a doctor. We're not a clinician. We can't draw that conclusion ourselves by looking at the medical record. The same as the doctors are there for the care of the patient. They're not there to be a coder. That's why they hire coders. So we need to get them both on the same page. So sometimes it's that eye-opening, wait a minute, you got a lot of problems here. And if they came in for an audit, they're going to take back all this money plus interest. So we definitely need to catch things ahead. So not all errors are overpayments. You could be, like I said, missing money as well. So it could be undercoding or leaving out a code that is relevant to what is treating the patient for. So documentation is definitely key, and we have to work anything that can make those providers work better and easier to get done what needs to be done is definitely worth the investment. Now, I didn't put it on here because, Alicia, I didn't find it. So you had said an ICD-10 is time-based.
Yeah, the counseling codes, especially the one that comes to my mind is the Z code for counseling for cessation of smoking. And my experience,
and I know in CPT, yes, it is. CPT is time-based. It requires to bill in a CPT, but I didn't know for ICD-10 it had to be time-based.
I'll have to find it.
Yeah,
we'll put it in the club, and then that way, But I remember there was one provider, and that he did beautiful documentation for, for people to stop smoking, and he did it for absolutely every single patient he saw every time he saw that patient. And it didn't, individually it wasn't much money, but he refused to put the time. So I think it was either $33 or $22. I can't remember. I know it was, duplicate, that he lost every visit. So if you saw 4 patients that you did that on, out of however many you saw in a day, that's $100 a day that you're losing in revenue. And you should get paid for the work that you're doing.
Work you're done, yep.
Okay, let me go back. That's good stuff. That was really good. We get a lot of questions like that. So that was a really good one. We're ready for another poll. What's your status in medical coding, billing, or similar medical business related job? Let me pull that one up here and launch it. Can you guys see us when we launch the poll, or does it fill the screen? I was always curious.
I don't see you, but sometimes it's weird. Sometimes
I never see you, but
I just see the screen of.
I mean, I don't see it on the screen either. So, but I didn't know if that was because I was driving or.
So the options here are.
Everybody's not asleep. They're pumping these out fast.
The options are looking at medical coding as a career, certified and looking for a job, or employed, or improve my current job situation and earn a new credential, or no, not pursuing employment at this time.
I wonder if this hasn't been affected by the whole COVID thing too. Okay, we've got 75%. I get to count down. 5, 4, 3, 2, 1, close.
21% looking at medical coding as a career. 18% certified and looking for a job. 33% employed, 24% improved my current job situation and earned a new credential, and 5%
Very
no.
good. Yeah.
Guys,
That's really good.
I know we just finished up a webinar with Alicia talking about risk adjustment expanding, and they're looking for a lot of people. You can check that live video out in our Facebook and YouTube channels. It just happened last night.
Yeah, that is really hot right now. It's always this time of year that it's really, really hot, but it just seems like every year it gets bigger and bigger. Oh, right. You get to go again. Let me go grab that real quick before let me take my...
So somebody wanted to know, why should they take coding before billing? Or is it even important? So they're confused with all the credentials. So what's going to help get the best job? So there's a couple things we kind of have to look at. And so I took AAPC's main credentials and a HEMA. So AAPC has, of course, the CPC, which a lot of them look for that, the CIC, depending upon what it is you're wanting to do, or the CPB as a different avenue of the office. A HEMA, they have CCA, Certified Coding Associate, CCS, a Certified Coding Specialist, and then the RHIT and RHIA credentials. So RHIT and RHIA, those require 2 or 4 year degree education to obtain and sit for those certification exams. But all the other ones don't really require an associate's or bachelor's degree. So the CPC, I keep wanting to say CPT. This certification they call the industry's gold standard. So, I mean, it's been well known that AAPC has the CPC certification, and that's kind of what a lot of people base their decisions upon. The type of job duties is based upon what somebody with a CPC credential can do. The knowledge that's obtained, of course, is anybody who's taken the exam. It's not easy. It's not easy peasy. And it requires a lot, which is why it's held to such a standard that it's not just anybody walks off the street and, you know, it's nothing you learn in a weekend to go in and sit for this exam. Even if you've been doing it 20 years, you still don't learn it in a weekend. So there's so many different things to it: medical terminology, anatomy, pathophysiology. What is that disease process? How does one manufacture to another? A word used often in ICD-10 is manifestation. Well, if you don't know about the disease process, you don't know what a manifestation is as well. Diagnosis and procedure coding, and even compliance, because compliance is listed on every single exam pretty much. So you have to know all that and be good at it in order to obtain your CPC. So it's a lot of information. Now, CIC is very similar to the CPC, requiring much of the same knowledge, but designed specifically for inpatient and facility. So you need to know your ICD-10 PCS, the IPPS, Inpatient Prospective Payment System, and your DRGs. Those diagnosis-related groups are also included in a CIC, in addition to what the CPC has. So it is definitely a lot of information to know, and it's all driven towards providing the correct code for the services that were rendered. Now, the CPB is a little bit different. That certification is designed for the revenue cycle with specific knowledge of insurances, contracts, appeals, the payment process, inputting payments, insurance coverage determinations, eligibility. A whole lot of other information goes into CPB that you don't even discuss in CPC or CIC. It's rarely brought up. So to be successful CPP billers, they need an understanding of CPT and ICD-10 because those are also questions on the exam. But we need to understand how the coder got that information and how they came up, you know, is it correct? based off of the medical record, based off of what actually happened. Is all the information correct? So we need to know that as well as a biller. You need to have that knowledge, maybe not so in depth of the medical terminology and the disease process, but you need to recognize codes, how to know it's the right code, how does that diagnosis go with that procedure code, things like that is still required. We still extract from a medical record because we want to make sure that when the insurance company says they're not going to pay that claim, well, why? It's listed right here. You need to be able to read a medical record and understand it. A lot of things like modifiers are on there. So modifiers, we kind of touch on them in CPT, but you really need to know your modifiers in billing. So kind of that entire circle from the time the patient makes their phone call till the very last time they pay their bill. That's all part of the revenue cycle. So everything in between, which includes coding. Now, HEMA CCA is similar to the CPC, requires terminology and anatomy, ICD-10 and CPT. The CCS adds a little bit of what the CPB does. You need to know reimbursement methodologies for the CCS. So we need to know a little bit about how those codes are affecting the payment. So a little bit more in depth. RHIT, RHA, every bit of the revenue process, coding, billing, inpatient, outpatient, compliance, administration, leadership, that's all part of the RHIT, RHIA programs. And again, those are 2- and 4-year degrees. So what do we do with those? The CPB, CIC, or whatever HEMA has, you can find careers. Typically, it's like data entry duties, whether that's the information given to you or you have to extract it from a medical record. Coding compliance. Are we coding properly? All of the NCCI edits, insurance companies. Claim verification. Is what's on that claim correct and accurate before it gets sent out to an insurance company? CPB works the claim processing and record extraction. They follow up. So a biller will follow up that claim. What does the insurance company say? Do they say that that claim can be paid, or did we miss a step and they won't pay it because we didn't have the patient try other alternatives before we did some surgical procedure? How do we appeal a claim? How do we tell them that we want our money for these services? Because look what we did. You're submitting supporting medical records and a lot of phone calls, or nowadays, a lot of it's online inquiries as well. So a lot of follow-up, a lot of emails, things like that. So it depends on what you want to do. So as of today, I just pulled up, today I pulled up one earlier. I went on AAPC's job listing board and I just plugged in CPB. And this is what one of the ads came back saying that they're hiring remotely for, is somebody with, and it said CPC or CPB. So their ideal candidate is goal-oriented, self-motivated, and proven high accurate biller. So how are we highly accurate? We need to know all of those steps of the processes. We need to know that our modifiers are correct. We need to know our coding's correct. We kind of have to have an idea of the other side of the coin, though. How do we get that money in? Because you have a commitment to being the best in the business, consistently obtaining every possible revenue dollar. So it's not just putting down a CPT code. It's also understanding, how do I get the most from that insurance carrier as well. And their baseline test requires demonstrating a knowledge in all aspects of medical billing. So you need to know some of that process. What's a PPO insurance? What's an HMO? What's a contract? What's an ABN that we fill out like a waiver with Medicare? And understanding the proper use of CPT, ICD-10, and HCPCS code. So how do we properly put them together? So it's a little bit of both, but they want to know some of that billing as well. So now, which one's going to be better for me? How do I know what I want to do? Well, that's something that each person has to think about on their own. kind of that. Where do you want to be in 5 years? Where do you want to be in 10 years? What is your goal? What's your ultimate goal? Many people like coding. They like learning something new about the disease process. I know Alicia's one of those people. Or they just feel comfortable in what they're doing and they don't like change. You know, I'm good with just entering these codes every day and extracting from the medical records, and I'm good with that. And that's fine. That's what people enjoy. And many billers, I call it an investigative process. I'm going to track that money down and I'm going to find it. I like doing that. And I like demonstrating my knowledge of the coding system by arguing with an insurance company and telling them, I don't think you're right there. So being able to do something different every day. A biller doesn't do the same thing every day. Maybe a coder does. You get your list of claims for encounters that the patients were seeing, and you're reviewing the record, and you're doing the same thing every day. People like that. Some people don't. So it's a personal, individual style. Does your goal include management? If you see that goal down the line, I want to be a practice administrator. I want to be a manager of a department. Knowing both coding and billing is a very well-rounded. Which one to do first? That's kind of up to you. You're going to have to know both if you want to do both. Personally, I think CPC might be a little bit easier to learn first because it goes so in-depth with CPT and ICD-10, and then you do the billing. Might make more sense. It does. It's a personal preference, actually. So, I mean, I think both are very important. I highly recommend people doing both. But you need to understand, if somebody in management, they need to understand that whole process, because they can look at it and go, okay, our revenues are down. Why are the revenues down? Oh, there's a slow up in our coding process, or there's somebody gone from, this department. This department is now losing people, or, so I can understand where things are coming from and how, or they change the rules. The insurance companies change the rules. So how do we adjust? So somebody who can understand the whole process is good. Where can you start? Getting that basic knowledge of terminology and at least anatomy is beneficial no matter what you do, no matter which direction you'd want to go, because ICD-10 and CPT are required either way. You don't learn as much with CPB, but you still should learn it because it's very important. Like I said, you need to understand that that person pulled the right code from that medical record, because if you don't understand what that surgical procedure is, and then you don't understand the codes to know if they pull the right one, how can you tell the insurance company that you should be paid? It kind of, you need that knowledge of both. But probably the best is networking. And right now, of course, there's not a lot of networking. You can network via LinkedIn or some Facebook groups, perhaps, for a specific specialty, maybe. But networking is definitely probably one of the best ways, because then you can ask other people, ask what they like about what they do, what they don't like about what they do. Do you like billing? What do you hate about it? What do you love about it? You ask me, I'm going to tell you my passion, just like my passion for Star Wars. You ask Alicia, no, she doesn't want to deal with it. So everybody's different. But finding the opinion of somebody, or an opportunity to shadow, maybe. I know coding, can I sit with you for a day and see what you do? Ask your manager if you can go to a different department and see what they do, perhaps, maybe after COVID. But, look at the insurance carrier's website and get a better understanding. I included the Medicare Internet-Only Manual, which is the Medicare's billing manual. It is pretty long. So it's got like 37 chapters in it, each one something different. It gives a little idea of kind of what you're looking at. Where do some of these rules come from? And because Medicare is the gold standard of insurance payers. So how do they operate? What will get you the best job? That, of course, depends on the person. It depends on your likes, your dislikes, your lifestyle requirements. Do you have 6 children at home and a spouse who travels often? You know, maybe, you know, something so in-depth that may not be geared towards you right now. But if you have opportunities available to you where you live, or especially right now, things going remote, you might be able to find another opportunity remotely. So your income level, how much do you need? How much? Typically, people with multiple credentials can be paid more. I wouldn't say that's a standard everywhere, but typically the census that's been done shows that people with more credentials receive a higher salary. And definitely it puts you in a different bracket, especially if you lose a job, then you have skills, or you move to another area, you have skills that are beneficial no matter what you'd want to do if you did both billing and coding. So.
Jennifer's right. We both like what we do, but we specialize in different things. And that's what's I think one of the unique and wonderful things about this area of medicine is there is such diversity. It is pretty exciting, actually.
Mm-hmm.
Let me just change screens here. I got too many screens open, I think. Oh, reviews. Boy does a good job of pulling these reviews. We get them in pretty frequently, and they're so up to date. You know, Terry Lopez says, "I'm so glad I purchased the Blitz with the BAT system. I passed my first attempt. Thank you so much." So if you have a testimonial, you want to let us know that you passed, absolutely do that. Go to cco.us/testimonials. And if you're wanting some help on, you know, where do I start? We have a great proven process, CCO's proven process, and that's a much longer website. So I'm not going to, it's how to pass the CPC exam or any credential. Oh, okay. With HPI documentation, who can document the HPI? I know CMS states qualified healthcare staff, etc., nurse, MA. It doesn't clarify who can document the HPI. If it is a scribe, yes, the provider needs to document, and he reviews and signs it. Other than a scribe, who would it be? Well, I was pretty sure I knew where this came from. I went and looked, and sure enough, there was in 2018 a change, and absolutely take some time to go out and look at that if you are not familiar with it. I did footnote it at the bottom, the link on how to get to this, and you're not expected to read that small print because I pulled out the important stuff, but I wanted to kind of let you see what it looked like on the page. So the Federal Register, and it's from 2018, Rules and Regulations. It is an extremely huge document. I don't know that I would want to go pull that up. So the question that came into this particular document was, what parts of the history can be documented by ancillary staff or the beneficiary starting in 2019? And so what I did was I pulled out of this particular paragraph, which was in that evaluation and management, the E&M visit frequently asked questions. It was an additional document that was asked off there. So I pulled out these statements. That any part of the chief complaint, because this was about the chief complaint, but it says, or history that's recorded in the medical record by ancillary staff. Now, ancillary staff would be anybody else, or the beneficiary, which means the patient, that's the patient, does not need to be redocumented by the billing practitioner. Okay, so I thought, wait, billing practitioner? Oh, well, the practitioner just means the provider, right? Whoever's billing. Then they went on to state, instead, when the information is already documented. Now, I'll stop right there and say, when you ask the patient to fill out a questionnaire, and they ask them the signs and symptoms that they may have. You've seen that document, I'm sure, or you've had to fill it out. And the patient states that, you know, they're dizzy, they've had a headache, etc. You know, and so once they're saying that once that patient puts that down and signs it, it can be included into the record as something that could be billed off of. All right. Now, the provider still has to attest that they reviewed it and acknowledged it, and they are including it into the medical record. They can't just say, okay, fill that out now. I don't have to worry about the signs and symptoms because the patient put all that down. No, he has to, or she has to, acknowledge that the patient's questionnaire was filled out. And then they could even say, you know, when or prior to the visit, I reviewed it, I, you know, asked questions about it, I clarified, you know, things like that. So again, now the patient's documentation can be used in the medical record as documentation that could be billed off of, as well as ancillary staff. So it goes on and states that the billing practitioner can review the information, update or supplement it as necessary, and indicate in the medical record, which this should probably be brought up here, shouldn't it? That he or she has done so. Now, this is an optional approach, and it applies to not just the chief complaint, but also the HPI, the PFSH, and the review of systems. And but the provider still has to do the review of systems in the physical exam. They have to do that. So then there's a caveat here. It says this policy does not address that who can independently take and perform history. So I thought, well, you know, they're saying, yeah, anybody can do that. But then they're saying, well, it doesn't really tell you who those specific ancillary staff people are. So can the MA, you know, can the CNA, can the, you know, LPN or LVN, or does it have, you know, does it have to be a clinician, a nurse, an LVN, and a RN? They don't actually address that, but rather addresses who can document information included in the history. So the article that is also footnoted here that I read, and I would, if you're interested in this, I would advise you to go read that article. It says the physician's fee schedule, what we just mentioned above that I took the excerpt from, says allows a physician to verify in the medical record any ancillary staff or patient documentation of components of E&M services rather than redocumenting the information. Now, when they say redocumenting, you have to clarify that. That means that it's going to be added into the medical record what that other person did, and then it will be acknowledged and stated in the document, the documentation, that the provider looked at it and used it. You know, you can't just say, oh, there it is. So that is really the final statement. So can an MA, you know, do that? Yeah, it says that they can, and they don't say who the ancillary staff is. So could it be the biller? You know, could it be the person in the front desk? You know, at this time they haven't specified. They just said who ancillary staff is. Therefore, the best compliance advice that I would give you is that I would have a definition in the office who the medical ancillary staff is, or you could have the person that comes in and does the cleaning could technically be ancillary staff, right? The person who comes in and fills up the water cooler could be ancillary staff. So have that defined in your compliance notebook. These are the medical ancillary staff. These are the staff that could or does document in the patient's record. And that your understanding of this rule allows for their documentation to be included, and that the provider does not have to redocument, but does acknowledge that this document was used, that was, again, put in the record for XYZ. Because just because you start doing this, if the auditors come in and they say, what do you mean you got the MA doing the HPIs or the history, the history, that's not going to work. And then you can say, well, this is our understanding. This is what we're doing in our office, is our practice, it's our compliance understanding that we have in our notebook. And then if they say, no, you can't do that, then you say, okay, we'll add it that you said no, and we'll make these revisions in the compliance notebook. So again, I'd be very careful with that. But quite honestly, if you have an MA in your office and you don't have an LVN or an RN there all the time, then they are going to be taking down this information. So just make sure it's clarified and clear to everyone in the office, that everybody signed off on it in your compliance notebook, and that the providers and the ancillary staff understand, and then move forward being consistent with that. So that would be the answer. And I am sure that this is why there was talk about it probably in this person's office, and wanted to know, hey, can just anybody do this? Or, the MA wants to be able to document. The provider doesn't want to have to keep rewriting what the MA wrote. So, very good question. And I'm sure that they definitely have, that you guys are probably hearing about it and coming across this as well. Hey, we got another poll. What's your medical background? Let's do that one real quick. The polls are so much fun. Are you a clinician, a provider, a coder, other, and you can write in the chat box, or none? Oh my word. There for a second we had 100% were coders, but now some other people are picking up. And this area of the medical field is really a great way. I don't know if you would call it moving laterally, but if you do, if you're a clinician and you want to get involved in the coding, hey, that's great. Many of the providers are getting credentialed just so that they have a better understanding. Plus, someone needs to be a provider that's the authority that can be the go-to person for your office if you have a multi-physician practice. All right, we are about to close. 5, 4, 3, 2, 1. Wow, look at that. 3% are clinicians, 67% are coders, 17% are auditors, and oh, I see an AMTA or EMTA. Kathleen, I'm an EMTA. Or was I an EMTD? I can't remember what mine. I was able to drive as well. I had some extra credential for driving the ambulance. Let's see, billers, auditors. Very good. Marcy, 4 years with the CPC. I work in the real estate department of a hospital. A real estate department. Wow, that's cool. Medical assistant, patient advocate. Wow, those are good ones. Okay. Thank you. Oh, I get to go again.
I was going to suggest maybe give it to Jennifer, just in case she needs to leave early. She can do that.
Okay, let me just skip ahead then.
Yeah, I think she's got the last one.
There you go.
Jennifer.
Okay, Jennifer.
And I muted you, so you have to unmute yourself, I think, Jennifer.
I'm sorry. Didn't realize I was making noises.
No problem.
So mine is going to be kind of similar to Alicia's. We're going to piggyback on each other. So a code for urgent care clinic and queries to providers. Again, one of these areas of, we're talking again about there's no chief complaint. How are they supposed to get the provider to understand that this is required? Well, and we're going to go into that a little bit. So some examples, they included some of the medical record documentation, so I just took out some of it. So some of the examples that they included with their question to demonstrate the confusion was, it says subjective. Coughing so hard he vomits. Mom suspects strep. Pulling at ears bilaterally. Okay. Subjective. Punched father in the shoulder last night for fun. Now has right ring finger pain. Okay, so is everybody reading that and saying, there's no chief complaint here? So one consideration in those examples is that term that they use, subjective. Subjective is the description of the patient's symptoms and the reason for the visit. Typically, there are answers to questions. Subjective. You are asking a question, how did this happen? When did this happen? And the patient's responding, right? That's part of the HPI is a subjective. So it's the patient's own words usually is what we hear. It's defined in some medical dictionaries as perceived only by the affected individual and not by the examiner. So this is what the patient's saying. And in this case, it was the mom because the patient was young in the first one. He was coughing so hard he vomited. I think he might have strep. There is cause for confusion because from the doctor's point of view or clinician or provider, we'll say, because we don't know their level, provider is, well, they told me what's wrong. They told me why they're coming in here. I suspect strep. Or, you know, I was having so much fun. Now I have finger pain. Is that a chief complaint? Are they using that for HPI? And we're going to get into that. So this is a long-held debate of the providers assessing the patient. So they're kind of probably wondering why there's what are you complaining about? I told you what they're coming in here for. So it should be documented why the patient was seen. Well, I did. They have finger pain, So it comes down to the insurance carrier and facility compliance, what Alicia was just talking about. So per CMS, in the 95 and 97 documentation guidelines, it says for chief complaint, the medical record should clearly reflect the chief complaint. I highlighted that ever important word there, should. It's not must or has to. It says should clearly reflect the chief complaint. That's one of those gray areas of why there's such ambiguity about this, because it doesn't specifically say it has to. And Alicia brought this up as well. So the 2019 CMS update the requirements to indicate any part of the chief complainer history that's recorded in the medical history by ancillary staff or the patient does not need to be redocumented by the practitioner. However, there's some discrepancies in their own guidance. So I did give that web link of where that's from, but then I went to, this is the CMS's documentation requirements. So when they talk about history, they say, of course, we know a little bit about history, right? It has to be problem focused or expanded problem focused. It has to be that. But if you look in that column, is under chief complaint, it says required for every single one of them, that it's required to have a chief complaint, but they just said they should document the chief complaint. So while documentation of chief complaint is required for all levels, the extent of the information gathered, depends on the nature of the problem. And then under chief complaint, it says a chief complaint is a concise statement that describes the symptom, problem, condition, diagnosis, or reason for the encounter. Wasn't I hit my dad in the shoulder in fun and I hurt my finger? The patient was coughing so much he vomited. I think he's sick. That's they kind of fit what they're asking for, but it doesn't specifically say the patient is here for XYZ. So the medical record should clearly reflect the chief complaint. That's where some of the problem comes in. So CPT indicates the chief complaint as a concise statement describing the symptom, condition, whatever. It's a reason for the encounter, usually stated in the patient words. That's where we get that from. When we level E&M, CPT indicates the E&M levels recognize those 7 components: history, exam, medical decision-making, counseling, coordination care, nature of presenting problem, and time. Nature of presenting problem is not indicated to be the chief complaint. The nature of the problem, how is that problem, and how is it now taken into account for what the patient, what else they have going on. What is the nature? Is it low? Is it, they give levels to that nature of presenting problem as well. They don't say that nature of presenting problem is the chief complaint. We can kind of read those two together. There's a lot of ambiguity. So many sites reviewed indicate the chief complaint must be present. Sorry, somebody's here to pick up furniture. So the chief complaint must be present. That's what a lot of these websites that I went to, I did a lot of research on, should the chief complaint be there? And hospitalist.org, a lot of journal papers, a lot of different societies, they all say the chief complaint must be present. When AAPC does their instruction for E&M coding, they indicate that the chief complaint is required. There's even an article from 2018 on the Knowledge Center that says you have to have the chief complaint. If none is present, then the service is now preventive. And then if it can't be found as preventive after you've examined the patient, then it's not billable. Now, NAMAS is an auditing society, and they go by that word should requirement, and it's best left for the auditing compliance guideline. So we need to remember now payment requirements, because to establish medical necessity, which is some of the insurance carriers' prime reason for payment is their medical necessity, the chief complaint can help determine that necessity of that service or procedure. Because why did they come in? Why are they there? And then you can take all that information between the exam, between the history, come up with what your plan is, and then you say, this is what we're going to do. But it all stemmed from why they were there. So it may not matter in the medical record where the chief complaint is, because we don't score it when we audit. We don't say, we don't give it 1 point. We don't count it as an HPI. The chief complaint shouldn't be used as part of the HPI when the provider is documenting, unless there's agreement among the provider and the administration that they allow the chief complaint to be included in the HPI. So no matter where it's in the record, it doesn't always have to be very first. It could be in what the doctor's evaluating and what he's dictating in some big paragraph. So the best solution, again, you can see CMS says one thing, AMA says something else, one society says something, people say it must be there. I bet we've all learned in CPT, or as a CPC, I'm going to get that right today, that we have to have a chief complaint. But nothing exactly says it must be there. So the best solution, again, is what Alicia said, that compliance manual. Your facility's compliance manual should indicate about chief complaint. So we can see it would be good for payment. It helps establish medical necessity. The insurance carriers might question it. And it comes down to the carriers too. CMS has one rule. Maybe Blue Cross has something else. Aetna might say something. So it'd be good to maybe research and then say 4 out of 5 say we need a chief complaint. We better indicate a chief complaint. Now we have to go back to the compliance manual, do a consensus with the providers and say, we need a chief complaint. This is where we want it to say. So no matter who documents it, when somebody comes in, it should say the reason the patient's here, or chief complaint, or some kind of verbiage so it's very clear to everybody. But facilities and offices would benefit from having a policy in place to settle this issue. And it creates consistency. So everybody's now doing the same thing. And the providers will like it because you're not always asking them. You're not sending them a query. You're not constantly bothering them. You need to do an addendum or, whatever the case may be. So if it's presented in that manner, providers are usually willing to spend more time hearing those alternatives. Because if we say compliance, we need to come together as one, because this is going to drive payment. This is going to help our billers do a better job, and this is going to keep them from bothering you. So, okay, I'll spend 5 minutes to listen to what you have to say if it's going to keep me 15 minutes of queries. So, probably not maybe the coder, maybe again, an office manager or the compliance officer might be bringing this up, but the compliance manual will be really helpful to also have a definition of follow-up. The patient is here for follow-up. Follow-up to what? Follow-up from 3 months ago when they were here for their diabetes check? Follow-up from an MRI that they had last week for their knee pain? Follow-up because they were here 2 years ago and just don't feel good? What does follow-up mean? So that needs to be expanded upon, and whoever is documenting it shouldn't just use the follow-up. Have a general guideline of what that should mean as well.
There should be a lot of coding means for follow-up. Don't you think?
Oh, yeah.
I get all kinds of them, yeah. Let me see if I can just make that go down. There, that was easier. Okay, so let's go back a couple slides and I'll go do that other one.
Sorry. Well, thank you. Thank you.
Yeah, no problem. We've got colon screening codes and modifiers. The question came in, when coding more than one colon technique for a screening, do we code as example 45385 with modifier 33 and 45380 with modifier 33 and modifier 59? Well, I got an answer for you. This was a lot of fun because I, again, don't do the CVT codes as much. So I wanted to double check what, what was out there. So first thing I did was look at the codes that they're talking about. Let's see what they are. So 45385 is the colonoscopy. It's a flexible one. There's different types. And you'll notice the BAT technique that we use, where everything after the semicolon is highlighted. So you could like underline flexible if you wanted to, and then it says with removal of tumor, polyps, and or other lesions by snare technique. That's key, snare technique. And then 45380 colonoscopy, flexible with biopsy, single or multiple. And then they mentioned the modifier 33, which is for preventative services, and they mentioned the modifier 59 for distinct procedural services. So what are we going to code? Ultimately, it's all about intent. And this is something that I would suggest, especially if you are a new coder or just learning coding at this time, you're wanting to get a credential. Intent is extremely important. You'll hear that talked about again and again. Next, what I did was I went ahead and divided up the two types of colonoscopies because, again, this is a great testing point, is what's the difference between a screening test and a diagnostic colonoscopy? With a screening, if we look at that first, that means the patient has no signs and symptoms, and it's population-based versus finding-based. What is the definition of population-based? That means when you turn a certain age, because they know based on the statistics actually that we've coded, that say you turn 50 and you should have a colonoscopy. That's population-based. Also, if you have a family history of colon complications, someone in your family had colon cancer, well, then that would be population-based. You have a family history. Anybody that has a family history of some type of disorder of the colon should have their colonoscopy more often, screenings more often than a person that hasn't. So again, population-based versus findings, meaning there's no reason to have it done other than it's a standard for medicine. Diagnostic, that's very different. Diagnostic means that there's signs and symptoms and they require further testing, or that we've found something, and so therefore we need to go ahead and do a diagnostic test to find out, to clarify what the problem is. So a patient comes in and they are having, they're anemic, they have rectal bleeding and lower abdominal pain. Well, there's definitely a reason to go in and see what the problem is, right? So that would be not a screening, but a diagnostic test, because they have signs and symptoms, and it's going to be based on the finding. Now, a little note, a billing note, Jennifer would be so proud of me for paying attention to the Medicare billing aspect. I did find and thought it was pertinent to let you know that Medicare does not waive the copayment and deductible when the intent for the visit is to perform a diagnostic colonoscopy. So that means that you better pick the right code, or it's not going to be covered for your Medicare patients. And you could be losing revenue. The patient could be out of pocket money that they shouldn't be if we're using the improper code. Medicare does waive the deductible, but not the copay when a procedure scheduled as a screening is converted to a diagnostic or therapeutic procedure. So this is what really makes sense. It's like they go in, and this is what the person's asking too. They go in on a screening, and they get in there and they find some polyps and they snare them and send them off for biopsy. So is that a screening or is that a diagnostic test, because it's two separate codes? Well, we're going to talk a little more in depth on that. So I found this fabulous article, and actually cited it twice, but it's the same article, but I used the content twice, that really breaks this down. It was really easy to follow, so I would advise you to go check that out. It's from Coding Intel. And they actually have a service that if you want to join them, I think you get access to a bunch of other stuff. I wasn't aware of them, but when I did, I was like, oh, I think I might consider that. 45378, colonoscopy, flexible, diagnostic. Notice we did the BAT technique. After the semicolon, we highlighted everything, and the word we wanted to jump out at us is diagnostic, and that's going to be including collection of specimens by brushing, washing when performed, separate procedure, meaning, hey, you're going to put another code in there if you did that. Now, for Medicare patients, by the way, there are HCPCS codes, and that would be G0105, and that's for patients that are having a screening and they're high risk. And then they have G0121. It's a screening, but they don't meet the criteria for high risk. Now, if say that now that I'm over 50, they keep saying, I got to go have a colonoscopy. If I was 65 and over and was on Medicare, I don't have a high risk, so G0121 is what I would be. However, let's say that I was high risk because one of my parents had a cancer, colon cancer. Then it would be G0. I would be a G0105. Now, these are only Medicare codes. They're HCPCS codes, but just have them in your wheelhouse, because really between the time that a person actually gets a colonoscopy and they become on Medicare, so I think they start colonoscopies around age 50 to the time you're 65, that's a short window of time. So you'll probably be using a lot of these G codes. With that being said, what's high risk? So I thought I'd put that in there as well. I'm not going to read these word for word because they're pretty straightforward. A close relative, a family history of a specific type of polyp. Let's see, family history of hereditary, a specific colorectal cancer. Again, a personal history of this type, or a personal history of cancer. And then it said inflammatory bowel disease, including Crohn's disease and ulcerative colitis. So, those are the pretty standard that says, hey, you're at more of a high risk to have them. So therefore, we want you having screenings more often, because it costs a whole lot more to take care of a patient with colon cancer than it does for a person that gets screened and they see something and then they just remove it before it becomes cancerous in the long run. So the diagnostic procedure codes that you need to be aware of is actually 45379 through 45392. That's the range we're looking at. And so I came up with some examples that I actually kind of based on that article that was so well written to give you an idea. So we have Mr. Feather, and I like doing these because I get to pick out the names. Mr. Feather is a 58-year-old, means he's not on Medicare, is seen for his first routine colonoscopy. He has no family or personal history of related issues. So it doesn't say that he's having a screening. So how do you know? Well, it's a routine, meaning they do it all the time without a specific reason why. That's what routine would kind of mean. And it's his first routine. So that means it's a screening. You can confidently say that's a screening. And there's no family history or other reasons to make him high risk. And so it doesn't have to just state screening. It's obvious it's a screening. So he would be a 45378, which is the code that we already talked about. And the diagnosis code would be the Z12.11, the screening for colon cancer. So Mrs. Flowers comes in. She's 55 years old, seen for preventative colonoscopy during procedure. A polyp is removed by stare technique. Now that's different because, one, he did state preventative colonoscopy. That means it's a screening. Preventative would be equivalent to that. But this time they actually state that they removed something. So we've got some other codes that we've got to deal with there. And that would be 45385, modifier 33, Z12.11 for the screening. And then for the polyp, the K63.6. Notice it's a different code, 45385, which we talked about a minute ago. So what happens when we have multiple colonoscopy procedures in the same session? And we've got to identify first the technique that's used, because just because they use a snare technique doesn't mean that they'll use a snare technique every polyp or lesion that they see. They have different techniques, and that's why you have such a large code range that we gave you. It's very well spelled out and defined in your manual. There could be a hot biopsy. It could be all these different types of things that they're doing. So don't worry about having to guess. You won't have to guess. It'll define it for you. One code is used to report the multiple procedures performed using the same technique. So if they took out 2 polyps via snare technique, you only report that one time. That's fine. And then if you do multiple procedures and you do more than one procedure was performed using multiple techniques, well, when more than one colonoscopy code is reported the same session, then you use modifier 59 to state that we did a distinctly different service. Okay, so we did one snare and then we did one hot biopsy. Okay, so that leads you into the questions for the patient, that the codes that they had. Absolutely, that's what that was. I thought I also defined what 33 was. Modifier 33. Modifier 33 was actually created for preventative services, and a screening colonoscopy is a preventative service. So yes, you would put the 33 on there, and but you would also do the 59 as well. Now, if their question was, do you put, I just thought of this, I probably should have thought of this there. Do you have to put the 33 on both of them? Well, I'm actually not sure about that. We could probably ask Jennifer, but I think you really only have to put it on the one, and then the other one a 59, because the 133 modifier tells the payer that, hey, they're there for a screening, but that's the intent. You have to have that for the intent. And then, by the way, we ended up using more than one procedure in the colonoscopy to do whatever we needed to do. And the 59 indicates that. So I think you could do the 33 on one and a 59 on another. Would they ding you if we put a 33 on both of them? No, I don't think so. I don't think it's going to be that big. I don't think they're going to bounce it back for you. Just have, yes, the answer is yes, you need both of them. All right. The CCO Club, we get to highlight that again. And the good news is that it's very easy to find, cco.us/club. We have several people that mentioned that they use the techniques, as well as you noticed with the graduates. And they are opening up testing again. I know some people that have recently taken their test at a physical location for the AAPC, as well as done an in-home testing where they used a video camera and stuff. There was some people that talked about how they were constantly being interrupted to adjust the video camera. So I don't know if that's conducive to your testing, how that would make you comfortable or not. But they are opening up some testing locations, different chapters. But not only in the CCO Club are you going to get benefits from helping you test, and as well as follow up and helping you with your courses, but it'll help you with CEOs afterwards, and opening up for questions that you might have. And these are questions that come in to the club just like that. And we usually pop those answers pretty quickly out to you. So are you a member of the CCO Club? Let's find out if you are. I'm going to find that poll. That one's, I've always liked this one. It says, your choices are yes, I'm a member, no, I decided not to join at this point, or no, I didn't know about it. Is it important? I think we probably explained the benefits of it. A lot of people really have you know, they're very thankful to be in there, and I enjoy answering questions and kind of talking to different people that are in there. I like to learn, and I'm always having to go in and look something up. And it's like, gosh, I didn't know that. You know, you learn something new every day, so your life isn't boring. You guys are not asleep. You are voting fast. Fantastic. Marie says intent, meaning is going to happen. Intent is what's the reason they're there to have something done. Whether they are able to fulfill the intent or not doesn't matter, Maria. It's like, no, we wanted to do this. We ended up doing, you know, we wanted to do X. We ended up doing Y, but the intent was X. So I'm going to close the polls and close. So it looks like 40% of you are in the club. That's fabulous. I think that's more than we've had in a long time. 29% no, not at this time. And it's always there for you guys. And you can join, and if it's not, you know, working out, just stop. You can do it as a month-to-month thing. Let's see. No, didn't know it was important. Now that 31%, now you know how wonderful it is. We have so many first-time people, so that would explain why you didn't know about the benefits of the club. And let's see. Oh, Lenore asked a question regarding the last one. She says, with the last question, wouldn't modifier 59 be used on the procedure that reimburses less? Yes. Yes. Good point, Lenora. Good point. All right. Let's keep moving forward. I got to get my cursor in the right place, though. So we've already taken care of Jennifer's question. Hey, it would be very beneficial if you guys could fill this survey out for us. I know that we've probably told you time and time again. Actually, a lot of you are new, so you don't realize that we don't advertise. We are probably 95% word of mouth. And so therefore, I'd be real curious to find out how you found out about us if it's your first time at our club. So this is real easy to do. Go to cco.us PE/QA202008. Do a survey. Let us know how we're doing. Give us feedback. Is there topics that you think that would be more relevant? Is there something you'd like to see us do in the webinars? Is there something we need to prove on? Or, hey, if this was a fabulous, weird, top of the world type thing, let us know that too, because we appreciate finding out that what we're doing is beneficial to you. We really enjoy what we do, and we don't want to be out here doing it it's not that we don't want to be appreciated. We want to make sure we're giving you value. So now it's time to pick our winner. Remember, you get either the Blitz, the video package, a year of the CCO Club Basic, or an hour session. My name's on there, but we could probably twist Jennifer's arm if you had a billing
we do question. Have a winner.
I don't think as much as Alicia, so
We do have a winner. You guys can hear me, right?
Yep.
Angelica Sahagan.
Oh my word! She just posted. I see your name right there. Lori just said, she says, if we join to take coding course, does that make it a part of the club? And Lori said, no, the club is a separate purchase. There you go, Angelica.
Yay!
You rock.
Sahagun.
Yep.
Wow.
Congratulations.
It's been watching these names go by.
Tell her what she needs to do, Alicia. Tell her what she needs to do. Go ahead.
Yeah. Oh, I'm sorry. I was like, I didn't quite hear that, Boyd. It's like, what? Okay, so it's really easy. Angelica, what you would need to do is we need you to send a message to the help desk. It's very easy. helpdesk@cco.us. And the ladies there will get in contact with you and let you know how to fulfill whatever you choose. So let's say you want one of the blitzes, you let them know which blitz you want, and they'll get that, get access. And if you want one of the other ones like the CCO Club, then it's real easy. She knows you let them know what email address you want to be logged in as, and they'll get you the login information. You get that for a year. Everybody's saying congratulations. So that's great. We're ready now for those other questions. So let me just exit. Sylvia, Lori has been in the background putting these together. And let's see if I can make that bigger. Is that going to be big enough, Boyd? Do we need to? Thank you, Sylvia and Lori.
Yeah, go into presentation mode again.
Okay.
I don't see it in there. Got two questions, it looks like. Hopefully they won't stump you.
Aha. Epilepsy or seizure are 56.9. Huh?
This is for you.
Did you say? Oh. When do you code epilepsy or seizure R56.9? If it's documented as seizure disorder, then it's always coded epilepsy. If the patient is on Depakote or Keppra, which are anti-seizure medications, then is it coded as epilepsy or just seizures? Can you explain when to code seizure diagnosis versus epilepsy? Well, I can. In fact, I just worked on a presentation for neurology on this, a neurology specialist regarding these, because R56.9, I can't remember, I think it does risk adjust. They both risk adjust, and that's what it was about, was risk adjustment. But when they say seizure disorder, that means epilepsy, as far as the coding manual is concerned. However, can a person have a seizure and not have epilepsy? Absolutely. Can a person not be on Depakote and Keppra and not have epilepsy? Maybe. So I can give you an example of that, whereas my son was put on Topamax, which was a it's used for different things, but it's also used for seizures. And that was the first medication that he was put on when he was 5. But most of the time, if you're put on medication, it's because they think you have epilepsy, but he didn't get his formal diagnosis of epilepsy until they confirmed that it was not febrile seizures. Again, if they're on Depakote and Keppra, then you can pretty well confident that's your line that it is epilepsy. But seizure disorder is classified as epilepsy when you look at the epilepsy code, which I don't have memorized off the top of my head as a G code, but it is defined in there when you look at the under the main part of the code. Seizure disorder is there. Convulsions is seizures, and that is the R code, convulsions. But there is kind of a little, I wouldn't even say it's a gray area, but most of the time you're going to get a diagnosis of epilepsy, especially if you go to a neurologist or a specialist. If you're just going to a PCP, maybe, but they're going to send that person off if they're having seizures and putting them on this medication. They're sending them to a specialist. And so they may not have the formal diagnosis on the first visit, but by the time they go to a specialist, no, you've got a formal diagnosis of very clearly defined. So my answer to you is, if you aren't going to query the provider, then Depakote and Keppra pretty much says, yeah, it's epilepsy, and you wouldn't use the R56.9. There are all kinds of reasons for people to have seizures as well. That isn't epilepsy. You could have it because you spiked a fever too fast, which is a febrile seizure, and that can happen to adults as well. You could be just the way your body reacts to trauma or conditions. So you could, have an asthma attack and throw a seizure. Whatever shocks the body. You could get hit in the head with a baseball, have a seizure, and you could have a migraine and have a seizure. My niece used to do that, and she had seizures because of the migraines. She doesn't have epilepsy, but the migraines were so bad that they heated up her brain and she had a seizure. So again, she was an R56.9, not epilepsy. So I hope that helps you. We've done some other things on epilepsy. COVID with heart problem. Ooh. So if the patient no longer has COVID, but has late effect heart problem, you would use the history code and sequela code, then a code for the heart problem. I think clearly, Jennifer probably would agree, there has to be a link that the heart problem was caused due to COVID. Just because a person has COVID doesn't mean they have a heart problem. Did they have the heart problem before they had COVID? Did the COVID exacerbate the heart problem? This is where, like Jennifer was saying, the disease process is so important. And here, like every time you look at the news, or, well, don't pay attention to the news, if you read a medical article or something, they said, oh, used to be the 3 signs and symptoms. That was it. Fever. What were they? They were fever, loss of taste.
That was back in March.
Yeah, dipsy. Yeah, now that was in March, and they were saying just these 3, and now there's like a dozen. If you have right great toe pain, it's COVID.
Well, now chilblains is COVID, and yeah, it's just
it is pretty extreme.
Well, and you got to remember too.
Would you agree?
Well, yeah, in ICD-10, remember there are coding conventions for sequelas specifically. Mm-hmm. And there's coding. You need to check out your history codes and find out when that's relevant. And then the sequela guidelines, because there's guidelines specifically for sequelas as well. So we need to make sure those are relevant. And, it depends on what their sequencing order is. And then, yeah, you remember the codes came out with was a big thing a couple years ago. So, they have to draw that link. It's not just, oh, this must be because of that. No, they have to indicate that it's because of that. So there has to be that documentation.
Confirm that it is a late effect of the heart problem, and then, the late effect of COVID, and then go forward. And yes, you would do the personal history of the patient had COVID, and then the sequela code. That's why having that little cheat sheet, make yourself up one that is very simple. Don't be doing out the whole code description. Just like one little word that reminds you that this is exposure code. This is the sequela code. This is the, whatever the other ones were. I can't think of one right now.
Yeah.
No, oh yes, the abnormal lab, things like that. So that would be really important. And just going to the next one. Oh, but Jennifer, did you agree that with me or not that 33 had to be put on both of those colonoscopy codes? If they have more than one colonoscopy procedure, and do you put a 33 on both of them if they were screenings and a 59 on just the one or not?
So much on colonoscopies when I was helping a particular person with some codes. And 33
I don't think
is
it matters,
insurance requirement.
Preventative.
And you're talking specifically Medicare?
No,
Medicare, you don't use 33.
No, this is not Medicare. Yeah.
Okay.
So I think that, put it this way, if we rephrase it, are they going to throw it out if you have 2 procedures done with the colonoscopy and they put a 33 on both of them?
No. And what time frame are you looking at here too? You're looking at 2 years, 3 years in between, because they can only have them per the insurance carrier, and 33 is an insurance carrier requirement. You can only have them every couple of years. So if it meets that criteria, then yes, you can have the 33, and they're not gonna do anything about that. So
it probably would be good to note then that whenever you're dealing with modifiers, like Jennifer says all the time, find out what the payer wants, because just because UHC wants you to do this, Cigna may not, or Blue Cross Blue Shield, and Medicare, of course, they got their own thing, but every one of them, so they may say, no, we want you to do it on everyone or whatever. So yeah, just wanted to verify, ask the billing expert. All right, guys. Well, I think I mentioned that our YouTube channel was Medical Coding Cert, and we would love it if you would jump out there on YouTube and subscribe to our channel. They've got that little bell that you can hit so that every time we drop a video, then you'll know about it. We do live videos 2 times a week minimum, right? And so, and there are times when we do more, and we've got, student events, club events, these CCO lives when we're trying to interview people. Is kind of fun and everything, and all kinds of subjects. So please do that. And look how many views, 4 million views on our website.
That's a milestone.
Our YouTube channel.
Just past 4 million. And 31,000 subscribers is a new milestone. We average about 500 people a month actually subscribing to the channel. So it's great to learn more about CCO and how you can get a lot of free training, get introduced to our classes, the way that we do things, and how we hopefully give value to people, and why you attend here, and why a lot of people come back.
You know what we should do? We should tell everybody we want to hit 40,000 by the end of the year, subscribers. So tell all of your friends and we'll have a big party. 40,000, woohoo!
One of those virtual parties, yep.
Yep, we could do that. And, oops, wait, I hit the wrong one, I think. Not just YouTube. Hey, we're on Facebook. I know Lori keeps up the Facebook and has things like neat words and their definitions, and there's a lot of conversation going on over there. It's a little more personal on Facebook, but please, if you're not already, if you're a Facebook person, add that to your list, and it's real easy. It's just the facebook.com and /cco.us, and with Facebook and YouTube, you can share it with people. I am always taking little video clips from YouTube and sending it through Messenger to different friends of mine to cheer them up. But now you can do that with your coworkers and friends. Say, hey, this video, they talked about COVID or whatever. We are not going out and doing any live presentations right now. We like to do that, but they're all virtual. But you know what? It's not a big deal for us because we've been doing virtual for almost a decade. We have the ability that here's some of the topics that we have in our wheelhouse, but if they're, you might check and see we've got some other topics that are recorded. And right now we're just doing our recorded ones, but in the future, in the near future, we'll start opening that back up and where you can do a special request and we'll do one live for you. It's real easy to find that one at cco.us/remote-presentations.
There's a survey, cco.pl. Throw that in this chat for those people who want to contribute. And I waited till now to add the handout for tonight. It doesn't have all the answer sheets and everything else like that. Again, that's in the CCO Club. But it gives you a little bit of a highlight of all the links and everything that we've been talking about tonight.
That's right. So you get the slide deck, but you don't get the answer sheets unless you're in the club. And that's a lot of heavy duty content on documentation and stuff that you can use. Again, the club. Remember, can I say it again? cco.us/club. I'm going to make it a thing.
Survey.
I think that's it. Oh, any of these other links might be beneficial to you. We have so many things going on, guys. We have sales all the time, that proven process that we talked about earlier. If you're new and you're thinking, well, what steps do I need to take? Then the proven process is set up to help you succeed. We have a lot of freebies, a lot of free practice exams. We have articles. Man, there's just I think of the practice exams the most, but there's a modifier grid in there. There's some other things. I'll have to go and look. It gets updated. Blitz videos. I think that's it. Oh, we're also on LinkedIn. We should. Well, you know what? I don't think we have a company LinkedIn page, but we're on LinkedIn. So look up Jennifer and I if you want. Boyd's on LinkedIn. Aren't you on LinkedIn?
We have a company CCO.
For your other company?
We have a CCO.
Yeah.
Page.
We do have a CCO LinkedIn?
Yeah,
okay.
Yeah.
Oh, that's right, because Lori posts on it all the time.
Pretty much.
Sorry.
Yeah, long time.
Yeah.
It's okay. We do a lot of stuff.
I should have thought of that.
It's late.
Yeah. Sorry, Lori. She does a lot of work in there. So I apologize for forgetting. So again, we have our touch out there, and that's a good place to find recruiters.
Yep. Cool. That's it. That's a wrap, as we like to say. Jennifer can go to moving.
Poor Jennifer. It's late out there on the East Coast for her too. Gosh, Jennifer's muted.
But thanks,
can't hear her.
Thanks everybody for joining us.
I was just saying, yeah, you're right. It's late.
Say a little prayer for Jennifer.
Nice. Thank you, everybody. Wax on, wax off. Hope you're all keeping safe. And thank you for being with us. Join us again next month. Second to last Thursday of the month, right?
Yes.
Yep.
Yeah.
And
I don't know what day that is.
We're always in Facebook Live and YouTube Live 2 times a week, Tuesdays and Thursdays. So come and check us out. All right.
Oh, I see.
Yeah.
Hey, I see more names now, you guys. It's rolling fast.
There you go.
Thanks, guys.
Good night, all.
When you'll stand and face your fear, in your life there's a star shining and your destination's near. So you're wondering, girl, is trouble here to stay? There's a new world coming your way.